Okay, we will start. Good evening, everyone from India, and good afternoon and good morning to people who have joined from other parts of the globe. My name is VK Kapoor. I'm at the moment working in the hepatopancreatico-biliary surgery department at the Mahatma Gandhi Medical College Hospital in Jaipur, in India. The Mahatma Gandhi University of Medical Sciences and Technology is a private medical university, first in the state of Rajasthan, which has 7 institutions, including a medical, dental, nursing, and other colleges. The Mahatma Gandhi Medical College Hospital is a 1,500-bed tertiary level referral teaching university hospital. The Center for Digestive Sciences includes departments of medical and surgical gastroenterology, hepatology, and HPB surgery. And to the best of our knowledge, we probably have the unique distinction of being the only institution in the country which has all the 4 departments related to digestive surgery. The Department of Surgical Gastroenterology was started by my colleague, Dr. Ajay Sharma, who is currently the head of the Department of Surgical Gastroenterology. We started the 3-year MCH fellowship training program when one of the senior most surgeons from the armed forces, retired Major General R.P. Chaube, joined the department in 2020. The liver transplant unit includes all these 4 departments, and the team is headed by the Director of Liver Transplant, Dr. Namish Mehta, who, as some of you may know, is also the Chief Transplant Surgeon at the Gangaram Hospital in New Delhi. And he is ably assisted by my young colleagues, Dr. Anand Nagar, Dr. Shashwat Sareen, and Dr. Vinay Mahala. The patients for transplant are worked up and prepared by my hepatology colleagues, Dr. Vivek Shashwat, who was my colleague for a long time at SCPGI Lucknow also, and Dr. Karan Kumar. The transplant anesthesia, we have a separate independent department of organ transplant anesthesia, which is headed by Dr. Vipin Goel, who is assisted by Dr. Gaurav Goel and Dr. Ganesh Nimje. And we have Dr. Anand Jain, who looks after these patients in the post-operative period. Just a word about Jaipur Surgical Tutorial. It is an online education portal that we started 2 years ago. We conduct a session every Saturday, 9 to 10. And those of you who are interested to join the JST, please contact Dr. Anand Nagar, my colleague in HPB surgery, who has been coordinating the activities of the Jaipur Surgical Tutorial for the last 2 years. I also want to put an acknowledgement for Dr. Avinash Tak, whose team, including Himanshi, who's managing the show today, have been providing the software assistance for conducting these sessions online. The masterclass today is being conducted entirely by the alumni of SGPGIMS. All of them are my former fellows and now able senior colleagues in the country in the area of liver transplant. And I can say with pride that in addition to these, there are others who, because of their unavailability, could not join, including Dr. K. Raj Prasad, who has recently moved from UK to US, Dr. Kadiala Ravindra, who is at Duke's in the US, Dr. Sanjay Negi, and Dr. Raghavendra Babu. So that completes the list of SGPGI alumni who are actively into the transplant, in addition to the faculty whose names are already there on the...
No, sir, not at come. I just checked, sir. I told sister hemoglobin.
Please mute yourself.
In four
Last
years.
word about me, myself. Some of you may be wondering that how can a person who has no hands-on experience moderating a master class on liver transplant? But that is the love and affection of my alumni who not only agreed to be on the faculty for the master class, but allowed me to moderate also. And I think my qualification to be a moderator is that I know very little about transplant. So I can ask questions which students probably would have in their mind, but would be hesitant to ask. And I'm also very happy to welcome Dr. Sonal Asthana, the current president of the Liver Transplant Society of India, who not only agreed to my request to put this masterclass to the notice of the LTSI members, but also agreed to say a few words to inaugurate the masterclass and to welcome the faculty. After that, I will introduce the chair and the speaker for the first session. Dr. Sonal, please come in.
Thank you so much, Professor Kapoor. Thank you, sir. I mean, it's an absolute honor and a pleasure to be asked to inaugurate such an august gathering online. I am not an alumnus of SGPGI. I'll add that disclaimer initially, but I do count Professor Kapoor as a senior mentor. So that counts for something. I'm like the Ikla before the Dronacharya, who sits separately and still counts you as a mentor. So definitely, whenever you sort of invite me, I would certainly, be honored to be part of this meeting. I mean, thank you to the Center of Digestive Diseases at the Mahatma Gandhi University Hospital for this invitation. I know that there's a lot of good work that's happened in Rajasthan, especially in organ transplantation, that has been spearheaded by this institution. This is a very relevant and a timely topic, and SGPGI must take the credit for producing so many stalwarts in the field of liver transplantation in India and abroad, who are able to ably cover all aspects of liver transplantation and talk about this. So thank you so much, and it's a pleasure to inaugurate this and now formally call this session open.
Thank you, Dr. Sonal. Thank you very much. So with that, we start the scientific program. For the first session, the chairperson is Dr. Biju Potakat, who is currently the head of the Department of Surgical Gastroenterology at Jaipur in Puducherry. And in addition to his activities in surgical gastroenterology and transplant, he has established a very excellent state-of-the-art simulation center at Jaipur. So Dr. Biju will chair, and the speaker is Dr. Palat Balachandran, who is one of the leading transplant surgeons of the country, currently at AIG Hyderabad. Biju, please.
Good evening, and the session will be about indications and contraindications for LDLT. So, Dr. Balachandar, you might be knowing, he worked in Medanta for almost 10 years, later shifted to Yashoda, and now he's heading one of the very big transplant program in the biggest GI center in the country, Asian Institute of Gastroenterology, Hyderabad. I request Dr. Bala to start the program.
Thank you, Biju. And my special thanks to Kapoor sir and the Jaipur surgical team. I can see that there is a lot of interest in transplant. Presently, there are at least 100 surgeons online, but the same interest is not being shown in people joining liver transplant per se full time. So I hope more and more people join transplant and become transplant surgeons. Transplant is a fascinating field. It gives back life. You can see that the same person on the left, who was barely able to stand, 6 months down the line is as fat as his wife. Things change, get back to life, and you should always remember, getting back a sick person who is useful to the family and society is the ultimate victory for medicine. Simpson is a typical example of all symptoms of liver failure. Whatever you name it, you can see it there. If you look at the incidence of liver disease, India stands 83rd. We are not very high up, but still, there are at least 50,000 cases coming up every year. This is a very conservative estimate. 50,000 cases coming up for transplant, out of which, if you cut out the foreigners being done in India, there's barely 2,000 who are actually getting transplanted. Now, coming to today's topic, indications and contraindications for liver transplant. I would say indications is an open book, ever evolving. There is no limit. It's like an expanding universe. What is a contraindication today will be a very major indication in the near future. This kid, 4.5 kg when we operated with bilirubin 30, so small that one day of intubation, the kid developed tracheomalacia, was so small. And you can see the kid just before discharge, always smiling, but still on tracheostomy. So the same kid would have been a contraindication. So more and more patients are being made fit for transplant. So before we dwell into indications, let's barely look at what is actually the contraindications. So they are shrinking. It's only an unfit recipient who has significant cardiac or neurological issues, or somebody who is not likely to be benefit to the family or to the society. There's no point getting a bedridden patient, elderly man who may not be of much use for you to actually do transplant and get him back. Active sepsis and infection. In these patients, strive to get rid of infection and sepsis and to get them transplantable. So it really is not a actual contraindication. Disseminated malignancy and of course, lack of donor. Now this list of indications you will see in every textbook. You can see that among the cholestatic disease, even biliary atresia, which is 1 in 10,000 births, is so common. There are so many patients for transplant. Now, luckily, what we used to face 10 years back, that is convincing the patient, was so difficult. Now, more and more patients are asking and coming by themselves. Now, there are so many walking examples of transplants. You can see metabolic diseases. It's like even hemophilia, A and B. A patient who is severely sick, if you do transplant in these patients, you get over hemophilia. Wilson's disease, so many of these primary hepatic tumors, fulminant hepatic necrosis. Now, this is the textbook indications. But when do you actually do transplant? For this, you need to weigh the benefits and risk of transplant surgery. Benefit is you are actually sidestepping the recurrent decompensation, multiple admissions, and in the long term, you get a normal person. Of course, transplant is a risky surgery, especially if the patient is sick. But in a relatively healthy patient, you could get almost 100% results. The course of the disease is something which you need to remember. It has lots of ups and downs, but ultimately, it is a road which keeps going down. Whenever there is an infective episode like SBP or sepsis, there is a sudden dip. So we need to pick up patients carefully when they are at the best of their health, not when they are down in the dumps. So there's always a tipping point. There are mathematical scores like MELD, CTP, which has been described. MELD 15 is when the risk of mortality at 1 year starts exceeding 10%. So when MELD is more than 15 or CTP score is more than 9, is the point where you start projecting transplant to these patients. Any of the end-stage liver disease complications like refractory ascites, SBP, significant or persistent variceal bleeds, or persistent hepatic encephalopathy, ACLF, ALF, and hepatocellular carcinoma, or the complications where you need to actually think of transplant. Now just have a look at these symptoms. A patient who develops HRS or AKI, the expected survival is only 6 months. A patient who has significant ascites, clinical ascites, the survival is only 1.6 months. All this figures I'm quoting from hepatology textbooks, nothing new. It is just that somebody who has a patient with ascites in follow-up doesn't seem to follow up the patient significantly enough to realize that their expected survival is only 1.6 months. Once SBP, the survival is only 9 months. Encephalopathy, the short-term survival is 2 years, but someone who has had encephalopathy long time back is just like any other patient. A patient with GI bleed, the risk of immediate mortality is 20%. And 6 months down the line, it is like any other liver disease patient. Let's see the symptoms individually. And we are actually talking of indications. So indications are based on the symptoms. A patient with compensated cirrhosis, that is first time diagnosed, asymptomatic, generally has 10 years to survive. A patient who has decompensated cirrhosis survives only 1.5 years. Hepatorenal syndrome, the type 1, the patients who are very sick, ACLF, with high jaundice, hardly any ascites, they barely survive 2 weeks. The indolent ones survive about 6 months. Ascites, 50% of stable patients over 10 years develop ascites. Once it is refractory, the survival is only 6 months. So ascites, you need to remember, is either diuretic resistant or intractable, that is side effects of medication. So whenever there is either refractory or intractable ascites, start talking of transplant. SBP is one of the major indications for admission in these patients. 30% of hospital admissions in cirrhotics is due to SBP. Mortality is 10 to 20%, and 6 month survival is 50%. So SBP is a major indication where you need to talk of transplant. So when to consider a patient for transplant? HRS or AKI, a patient with HRS or AKI, known patient, already on your follow-up and being actually worked up for transplant. When the creatinine is showing a downward trend, you should take up for transplant. You may not be able to get the creatinine values to normal. This is something very controversial. I am not actually going to dwell on it right now. ACLF, I'll be coming to this. The last one, that is acute liver failure, Dr. Shaleen is going to talk next, so I'm skipping that part. So let's first take acute and chronic liver failure. This is a condition which is seen in a patient with a pre-existing chronic liver disease who suddenly becomes sick because of some predisposing event. The bilirubin more than 5, INR more than 1.5, ascites encephalopathy within 4 weeks. The mortality in these subgroup of patients is 15 times more than that of chronic liver disease. Etiology of acute decompensation could be alcohol binge, any drug induced, superimposed viral hepatitis. These patients developing portal vein thrombosis. Cirrhosis is actually a coagulogenic syndrome where portal vein thrombosis happens in the long run. Any ischemic insult, any extrahepatic insults like trauma, surgery, bleed, infection, etc. can suddenly decompensate these patients. Our own study of 73 patients during 2 years of corona, which was published, we could operate 55 patients and we could actually achieve 75% 5-year survival. Few of these patients actually died of fungal infections, so that's why it was 75%. And we found that those patients who had steroids actually had a little bad prognosis, but those without steroids actually did as well as any CLD patient whom you take for transplant. Now, liver transplant for HCC, as in this masterclass, HCC has not been focused, so I'm just I'll dwell a little more. So you know Milan's criteria, UCSF, those within Milan, that is less than 5 centimeter tumor, you can have almost 85% cure. You should remember that these patients, the liver is very shrunken. A 5 centimeter tumor in a shrunken liver is a big tumor. Large tumors, but still within UCSF, you can have 70% survival. Outside UCSF, you can still have about 60% survival. So these patients who have advanced tumor, who used to be a contraindication earlier, can be downstaged and taken up for transplant. Patients with AFP more than 500, patients with tumor thrombus of the main, right, or left portal veins, or tumor in the hepatic veins and IVC involvement. We have now various modalities to actually downstage and take them up for transplant.
Bala, you have 3 more minutes, please.
Yeah, I need to. So I'll just show the photographs. So this is a patient who had TACE and later liver transplant. This was a patient who had a massive tumor involving even the diaphragm. We went ahead, did liver resection. A year down the line, did transplant, still alive at 5 years. He had even right branch portal vein thrombus. You can see the liver is not of good quality when we actually did the resection. This is a patient who had tumor thrombus, the right branch of portal vein, tear followed by transplant, still alive at 3 years. You can see the massive tumor on the right side, tear followed by SBRT. Almost everything seems to have been resolved, underwent transplant later. Now, colorectal cancers, best results you can achieve in patients who had primary resection 2 years back, stable disease on chemotherapy, and no positive nodes in pericholectal tissue. This may have more acceptability with LDLT. All the Western literature is based on cadaveric transplants, where the discarded or which cadavers which nobody were willing to accept were given to these patients. Neuroendocrine tumors, especially the good quality, the good prognostic ones, have excellent 10-year and 5-year survival, that is 97% and 51%. Alcohol indications are changing. Now we don't even wait for 3 to 6 months of abstinence. The disease severity is what actually tilts the balance in favor of transplant. NASH progressing. It took so many years for us to actually start walking, but very few years for us to become obese. Now, another important thing which tilts the balance towards surgery is the cost. Surgery is one-time cost. Chance of becoming normal is about 85%. Medical cost at 2 years is actually more than that of transplant. This is what something we should remember. And liver transplant in 2021, where do we Indians stand? You can see that the number of living donors done in India was the maximum. Yes, cadaveric transplants were much higher in US, UK, and China. But in India, we did the maximum number of living donor transplants. Yes, cadaveric transplants are also picking up, and I hope it picks up more. Well, with laparoscopic donor hepatectomies, especially, and there are so many other changes happening, the acceptance of transplant has gone up. Over the last 8 years, out of which about 3 years was Corona, we did about 850 transplants, and out of which about 680 or nearly 700 were living donors. And of late, most of our donors have been laparoscopic. The mortality has been about 5%, and we could achieve about almost 85% 5-year survival. I would summarize by saying indications are increasing, contraindications are decreasing. Nothing goes by book. Prospects are huge, and need for more surgeons, centers, and cheaper surgeries is what is required. Ultimately, it is the skill, perseverance, and passion. It's a culmination of GI surgery, general surgery, vascular surgery, and micro-invasive surgery. And we should all remember that making young surgeons competent is what is required. You never know. Years down the line, we may require them to help us as well. Ultimately, the team is the key to success. Thank you very much.
Thank you, Dr. Bala. Dr. Kanwaljit Singh is here. Yeah.
Yeah, Biju, please.
Yeah, I'm there.
Yeah. So I just want to start with one question. So, Dr. Bala, you're telling about the indications are ever expanding, and probably one of the major reason for expanding the indication is basically related to the availability of organs or availability of willing donors. So the graph is almost sometimes corresponding to that aspect. So what is your opinion about that?
I would say it is a mixture of everything. Skills are increasing. Experience of managing sick patients is increasing. And yes, now the acceptance of transplant has been increasing. Even 5 years down the line, we used to struggle so much to convince the patient. Now it barely takes a few minutes to convince them. In fact, they come and ask for transplant.
Dr. KJ Singh.
Yeah. Good evening, Dr. Kapoor and Dr. Bala and Dr. Biju. It's been a splendid, short and precise encapsulation of the wonderful topic, though it's too exhaustive. So I'll set the ball rolling till we have more questions from the floor. Dr. Bala, my first question to set the ball rolling is, so many times we see a patient of chronic liver disease coming to us. Now, we are not in a specialized liver transplant center. And when we sound the alarm for the transplant, it's usually quite late, or maybe not the right time. It should have been done much earlier. So you've given a very when to sound the alarm. What is the right time to get the family introduced to the concept of liver transplant as and when the patient is coming to the OPD, so that they can gear up? Maybe not immediately, but they can have it in the back of the mind.
Well, this is what my initial slides were showing. Well, yes, all this MEL score, CTP score is actually theory.
Yeah.
So what do you need is, when they come with any of these complications, like refractory ascites, patient's performance status going down, not able to go on with his routine activities, losing weight, sarcopenic, kidneys getting affected, any of these issues is when we should start talking of transplant. Medicines, medications help when the patients have minimal symptoms, but when the decompensation starts actually affecting his life, that's when we should start talking of transplant.
If I suppose a patient is coming with an index GI bleed, variceal bleeding is there, and is placed on the standard treatment for variceal bleeding, and the variceal eradication has been achieved with endoscopic and pharmacological measures, and patient is stable, would such a patient would at some time require transplant if he's going stably? And similarly, a patient of ascites who's been controlled medically and is doing pretty well, should you introduce the concept of transplant to them? How many of such patients will go for transplant eventually?
Actually, in the present era, it's better to start talking of transplant at a much earlier stage. A patient who has had an index GI bleed, otherwise physically fit, may not require transplant immediately, but the disease always shows progress. So if you start talking of transplant now, maybe a couple of years down the line, when the actually symptoms start, when they become sarcopenic, when the medical management starts falling short, so you can't really press the trigger at that point. The nail should be you should start hammering the nail a little earlier.
Is somebody following the questions on the floor, sir? Can we introduce the floor questions? Am I supposed to do that? I could.
Yeah, if you want, I can read.
Bala, please take the questions in the chat box. There are two questions in the chat.
Because if there's none, then I'll keep the forum active. But if there are questions, then I think you should keep them answered.
Yes.
Well, the first question was, have you ever had to encounter where you had to actually abandon recipient hepatectomy? Well, those days are actually gone. Now with our experience, in fact, most of the recipient hepatectomies can be finished in an hour and a half. However sick the patient is, it's very rare, and with our excellent anesthetists, these things don't really happen.
No, this might be related to, Dr. Bala, this might be related to the malignancy angle also.
Yes, that is the next question. Yeah. So,
no, HCC, yes, what will be your...
yeah, for with the present workup for HCC, what you're saying, having to give up surgery, although if it's an advanced tumor, we do recipient first, but to date, it has never happened that we have had to abandon the recipient surgery. And there's another question that is your transplant for hilar cholangiocarcinoma, Mayo protocol. Well, we have never succeeded in doing that yet. I don't think, I really doubt if anyone in India has done it so far.
Cholangiocarcinoma still remains a contraindication, that means? Cholangiocarcinoma still remains a contraindication as a bigger subset?
It is not at all a contraindication. It is just that our patients come much later and they are not really able to go through the entire procedure of chemo, and it's a long procedure. So I have never succeeded. We have tried in at least 7-8 patients, never succeeded. Now LDLT versus DDLT outcomes, they are totally different subset. There's no point comparing them. And Yes, there's one interesting question. Advanced HCC and immunotherapy for liver transplant. Yes, we have had at least 5-6 patients where immunotherapy has done major, I would say, magic, and we have been able to actually transplant them. Even now, we have one patient who had very advanced tumor involving even the middle hepatic vein, seems to have necrosed completely. AFP has from almost 5,000 has come down to about 15. Well, we are planning transplant on him, so it does happen in a limited number of patients. And primary transplant to Kasai photoenterostomy. Well, most of the patients come to us post Kasai, and if they come without Kasai, we actually tend to as I was showing that kid, there is no age limit, and there is no weight limit which used to be there, although everyone prefers that the child should gain a little more weight. But ultimately the underlying point is you should be able to take the patient before the child becomes septic, and there is really no minimal age to do liver transplant. Well, these are the questions which were actually there.
Bala, may I ask, so when dealing with ALF, now we all know that ALF may have spontaneous improvement also, and ALF may deteriorate into a not salvageable situation. So how do you handle the ethical dilemma that when and to offer transplant, and when is it too late to offer transplant when the outcome will be very, very poor?
So actually, acute liver failure, I have skipped in this talk because Shalini is going to talk next. But your question is very pertinent and to the point as usual. So I need to answer that. It's a difficult question to actually answer also. We do tell transplant at the earliest. A lot of them have financial issues, no donors. So there we are helpless. But we can delay till the point where there is significant cerebral edema. In fact, any of these patients, till they develop convulsions, we keep the line open and keep them ready for transplant. Sepsis is another point, which sepsis patient going on significant inotropes, especially 2 inotropes, is where we draw the line. So significant cerebral edema and sepsis. Renal issues, we generally take them up for transplant and just explain higher risk.
There's another question from Ajit Mishra in the chat.
Well, we don't come across much yellow phosphorus poisoning in our part of the world. It's much more commoner in Kerala. So their experience with yellow phosphorus poisoning from literature has been pretty good with excellent survival.
Dr. Bala, if the MELD score, as I understand, was initially for organ allocation priority, right? Now, since LDLT does not require a graft from a cadaver, so the allocation problem probably does not apply to LDLT because each patient will come with a donor, as at least in India. So has LDLT relaxed the MELD criteria for transplant, or are they the same the scores at which you would consider transplant?
Well, again, coming to that point, as you rightly said, all these mathematical scores are basically for cadaveric allocation. But the underlying thing is, unless the patient is significantly symptomatic, we really don't offer them transplant. In fact, unlike what the Westerners say, that LDLT patients come up early, it is not like that. The LDLT patients are actually more sicker than DDLT patients. When they have the donor, they would like to wait till they become symptomatic enough. They don't come up as early as a cadaveric donor. In fact, when we post our patients for cadaveric donation, rather when we list them, that is the more stabler patients who get listed. The sicker patients are always offered living donor transplant. So MELD score is not really the point which actually tilts the balance for living donor.
Biju, I think we need to close. Please give a concluding remark.
Yeah, thank you, Dr. Bala. I think most of the issues are covered in this brief time. It's a very vast topic, and the points are really precise. And we'll close this session. Thank you, Dr. Bala.
Thank you. Thank you, Biju. Thank you, Bala. Thank you, KJ Singh.
Thank you.
I forgot to introduce KJ Singh. KJ Singh is another alumnus who's now working as a GI surgeon in Jalandhar. And as he said, he's not into transplant, but that is the group of people this masterclass is meant for. All of us should know the basics of transplant. I must also inform the audience that Dr. Bala, although now he's into transplant, when he was with us at SCPGI, he had a first author publication on gallbladder cancer in Cancer, the very prestigious journal. So thank you, Bala. Thank you for
Thank you,
all
sir.
that. Yeah. So we now move on to the second section.